request we all come back after the health break. We should all be back. Hello? I request all the presenters who are supposed to do their presentations kindly come up front. All the presenters. All the presenters who are to do a presentation after the health break, kindly come forward. I just have two. Thank you. Thank you. Thank you. I think all the presenters for are already here, and we have the session chair, Dr. Abi Mwashi, to take us through. Dr. Abi. Thank you so much, Dr. Abi.
Thank you, everyone. And look to your right and look to your left. And I hope you do realize that you're seated next to a group of workers who can shut this country anytime, any day, and for however long they want. That's how important this caucus is. That's how important healthcare workers is. And it's not me blowing my own trumpet. I will not say that we are the most important group of workers in the world, because if I said that, people will say that I'm arrogant. I will not say that if it was within our powers and might, nobody here should be earning less than a six-figure salary and high six-figure salary. Because if I say that, then the government officials like Dr. Andrew Mulwa will say Mwachi is greedy and self-serving. My name is Abi Mwachi. I'm a general and laparoscopic surgeon working in Mombasa. I recently got the extraordinary privilege to be elected to be the chairman of the Doctors Union, KMPDU. A task that we are taking on quite well, rough but well. We're enjoying the bumpy ride. As we sit here today and try to pacify before I invite our guests, we also have to be alive to the facts that the healthcare situation in this country is taking a very bad downturn. And that the next session is going to talk about COVID, but the biggest virus that has eaten and infiltrated us is a virus called county governments. What started as a good dream in 2013 has ended up to be some travesty of justice. We see hopeless, helpless, county officials running healthcare in a manner that is not supposed to be run, and when you tell them, they don't listen. Chinua says that if the frog came out of the waters and told you that the alligator is sick, will you doubt them? We have health workers in Mombasa on training, being recalled, haven't been paid for 5 months. Others in Kitui sacked. Others in Taita Taveta on strike and threatened. I mean, if the same notion continues, we are very much like a man running down a hill very fast with their eyes closed and their mouth wide open. As we are tackling COVID issues, let's also try and get some vaccination against the biggest virus called county governments. Continuing the same trend, we'll be rendering this country to be as salacious or useless as a three-legged donkey. Having said that, and since we have decided that we'll not be in a mood for fighting anymore, but engaging and working things forth, allow me to introduce my co-chair, Dr. Anne Baganatra. She's a dentist. We'll be taking cues from each other. And at this juncture, it is my utmost pleasure and privilege to invite the topmost unionist, one of the founders of the union, carrier of placards, back then in the years, until we went to Makueni, then now is the DMS, the Minister of Health, Dr. Andrew Mulwa. He'll be tackling the topic of impact of COVID-19 on UHC. Thank you, Dr. Please.
Thank you, Dr. Abi Mwachi, my chair. I still believe I'm still a member of the Doctors Union, member number 1599. Good morning once again. Is it still a morning? It's an afternoon. Good afternoon. I think, as I had promised, I would appear now in my capacity and to share my experience in the journey that Dr. Abi Mwachi has just mentioned, that indeed I have been privileged to serve the national government before devolution, to serve as the pioneer group of CECs, serve as the second term CEC, and now serve in the Ministry of Health post-devolution. I think Dr. Abi Mwachi has already mentioned the disgruntlement and the issues, and pointed out very ably so that the biggest animal in the country is called counties. We would have a conversation about that, but I would say this convention will have lived its rightful purpose if it's able to bridge, identify, and bridge that gap between how health is being run today, how health is supposed to be run, and we ask ourselves, between the ideal and what is happening today, what are the critical things that every stakeholder, every player must play so that we move towards the ideal? Because unfortunately, having worked as a chair of CECs for health in this country, the one thing that I will tell you, from Lamu to Turkana, Busia to Wajir, the best performing county departments are called health. You can go to any county and you ask the county leadership, who is the governor, the CECs, and everyone, which is the best performing department in the county? They will say the health department. the healthcare workers will always, almost always say, no, that is not the case. In fact, it is the worst performing. So, what are we dealing with? Are there issues of perception or unmet expectations? Or indeed, are the counties oblivious of the real issues that affect the healthcare worker to the extent that they think they are doing well, while in reality, they are actually doing badly? That is a conversation, an honest conversation that this convention should have. I want to believe there are enough representations of the counties and the Council of Governors. Despite having Governor Nyong'o, I believe in this convention we will have proper representation so that we have honest conversations without pointing fingers, without saying who is wrong, but what is wrong. If we get that right, I am sure this convention will be looked back as a turning point for delivery of health in this republic. All of us, beyond being healthcare workers, are Kenyans. We endeavor to have a well-managed healthcare system with healthcare workers who are happy, in the right skills, in the right mix, and Professor Nyong'o has already alluded to that. So I will go now straight to, I had carried up our PowerPoint presentation, to the issue that we are supposed to discuss, COVID-19, the impact of COVID-19 and UHC. I think all of us today, and I can see a lot of us are not masked today, courtesy of our cabinet secretary's pronouncement last week. When I joined the ministry, there are colleagues that I had not met before, and we worked very closely for a long time, maybe for a month. We were planning something in Kisumu. So when we went to Kisumu, I met this gentleman who we have been working together, I'll not say the name, for a long time, probably meeting almost every other day. And after a month, I met him without a mask. Then I could not recognize him. So in other words, the world as we know it changed from 2019 through 2020 as a result of COVID-19. I think, and if we never learned this lesson, that health may be and is the most important actually sector in delivery of services in any republic in this globe. If we never learned, we were all asked to stay home. And that, I think, was a turning point for the health sector to actually recognize its place in management of security, in management of a country, in management of global politics, in management of everything. We, all of us, would expect the moment that countries would come to a standstill, where you can't move from one country to another. You can't move from your house to your neighbor's house, was as a result of nuclear war. All of us, prior to 2020, were thinking nuclear war is what would make the world come to a standstill. But courtesy of an unseen virus, we were able to have the world put upside down. And that has affected the health sector, and we were called to be the frontline, the military of the new war in terms of public health emergency. And therefore, what this means is these conversations that we are having about the health workforce in this country are very, very important. They are timely, maybe late in the day, because this should actually have happened before, so that we prepare for the next pandemic, for the next public health emergencies, and recognize we are at the same level as the KDF of this world, because indeed we are. And we have fought a battle like KDF are doing in Somalia, or what's happening in Ukraine. We are the soldiers. So we need to have this honest conversation about that indeed the place value of health workforce. And when we talk about health workforce, it is all cadres. Everyone has a role to play in this. Of course, COVID has affected the globe, and of course we have more than in Africa, we have more than 11 million people who have been affected by COVID-19, resulting to over close to 250,000 deaths, with a case fatality of 2.2, which is slightly higher than the rest of the world. of course, in the initial days of COVID-19, we thought the African scenario was better, but in terms of mortality, we are slightly higher. But of course, because of younger population, because of many other factors, we were not as adversely affected as most of the developed countries. In this country, we have, of course, over 320,000 persons who have tested positive for COVID-19. Thankfully, 303,000 have recovered. Unfortunately, we have lost 5,600 persons to COVID-19 with a case fatality of 1.7%, which is slightly lower than the African average. In this, of course, healthcare workers have not been spared, and it's quite sad. We have had to have over 10,000 healthcare workers affected by COVID-19, and have lost a number of healthcare workers to COVID-19, and we want to pass our condolences to those heroes and heroines who we've lost in this war to COVID-19. Universal health coverage was declared part of the Big Four agenda. It's a journey that in this country that began immediately after independence. Part of the three independence government agenda was to fight disease, poverty, and ignorance. And disease is where health sector came in as part of the government priority. This journey has metamorphosized over the years. The country being a signatory to the Amata Declaration of 1977, the SDGs, all of these are the SDGs, the Millennium Development Goals, and the SDGs now aimed at pushing the country towards protecting the citizens against catastrophic health expenditure while accessing health. Indeed, in 2017, the president, after inauguration, declared universal health coverage as part of his Big Four agenda, that by 2022, and Professor Nyong'o mentioned this, that citizens of this republic will have universal health coverage. With the new amendment to the NHIF Act, we expect by the end of this year to have regulations that will ensure that every citizen has universal health coverage, using NHIF as the vehicle that will deliver NHIF. But that will call for not just looking at NHIF as the organization that we know, but looking at NHIF as a strategic purchaser of health and the health system, which has infrastructure, as technology, as human resources for health, as healthcare services, tweaked in a way that it can deliver universal healthcare. Like Professor Nyong'o already mentioned, the value of community health, or the value of communities, the value of households, the value of the family, the household is going to be very, very important to deliver UHC. I think we must agree that in the global response to HIV, to COVID-19, I talk about HIV a lot of times, don't worry. The global response to COVID-19 has been, one, guided by a military approach. Courtesy because this is a new disease, began in some part in Asia, and the response that they did was indeed a military approach to a public health emergency. I am sure colleagues who are in the public health space will tell you that may not necessarily have been the right way to deal with it, but being the origin of the disease and having not known much, the rest of the world copied what was happening in China, and that is why we find ourselves having military approach to containment of a public health disease. I think we have learned a lot of lessons as a globe, as a country, and I think now you can see countries start relaxing, while we actually have a resurgence of COVID-19 in some parts of the world. But we are able now to learn how to live with the endemicity of the disease. So I will want to highlight a few issues on the issues of universal health coverage before and after COVID-19. we still have not been able to reach the Abuja Declaration of allocating 15% of national resources towards health. And this is a commitment that the government, African governments gave in 2000 or 2001, but we have not been able to attain. I think the highest we have gone is about 9.8 or thereabout. This is combining both the county and the national resources basket. And there's a difference between allocation and actual expenditure. And that is sometimes where you go to counties, and have been counties, and counties will tell you, oh, we have surpassed Abuja Declaration, so we are doing 30%. It is 30% of what? The devolved resources are 10%. Okay, they say 15%. Don't quote me. It's 15% of the national resources. So when you look at 15%, 30% of 15% is what? It's 4.5. So when each county allocates 30% as a minimum, we are actually talking about allocating 4.5. So the national government should have 11.5 if we are to achieve 15%. So, and national government usually allocates about 6%. So therefore, we still have a long way to go for us to achieve Abuja Declaration. An assessment was done for Kenya's readiness by the ministry, Kenya's readiness to deliver UHC, and of course before during the pilot, which was done in 4 counties, assessment was done for readiness of counties to deliver UHC, and it was found that the overall readiness was 38.4% of the entire health system to deliver UHC. So therefore, a lot needs to be done so that we move towards achieving UHC. So only 18.4% of hospitals had all the items required in the outpatient consultation rooms for suspected COVID-19 cases. This is an assessment that was done for readiness to address COVID-19. And only 26.2% of the required bed capacity for critical care were available in the country. The impact of COVID-19, the UHC, utilization of both outpatient and inpatient healthcare services reduced in March 2020. Of course, this is resulting from the population fearing to get infected with COVID-19. There was a significant disruption of health delivery in the country. And this led to increase in poor outcomes, maternal mortality, child mortality within our communities. The health workforce was also affected adversely. Professor Nyong'o mentioned here that a lot of healthcare workers went through mental health issues, working long hours, being the only person, and all the stigma that comes with having, because a lot of people do not know the disease, having come to contact with people who are COVID-19 positive, and that alone exposed our healthcare workers. We have, and I mentioned that we have lost quite a number of health professionals as a result of COVID-19 who have been exposed through the work environment. The issues of maternal and child health were significantly affected, and I have already mentioned that. Maternal mortality and prevalence of contraceptive use went down, and immunization services also went down. Then there was a major disruption in supply chain. I think what Kenyans remember is the COVID billionaires and the KEMSA stories that a lot of people made billionaire, and our cabinet secretary keeps joking that he has never understood how billionaires can be made out of millions because the available budget was in millions, but that's for another day. So disruption of supply chain. To date, we have not recovered from disruptions of supply chain that has been necessitated by COVID-19. I think you are all aware that HIV testing, especially the viral load testing and EID, early infant diagnostic testing, has not been happening in this country for close to about 6 months until sometimes in December when we resume. This is as a result of disruption of the global supply chain because the suppliers, the manufacturers focused their energies on mitigating against COVID-19 and therefore to restore our supply chain. To date, we do not have buffer stocks for ARVs, for example, in the country, because the supplies that we have, usually we have buffer stocks of about 9 months. I think on average we have buffer stocks of between 3 and 6 months as of now. So in infrastructure challenges, of course, a lot of conversions that had to happen in order to have COVID-19 beds, to ICUs and everything. Human resources, we have ICUs, and I have known so many counties that have ICUs, but if they actually got 2 cases of COVID-19 patients who require ICU care, they have 20 beds, but they can only take care of 3 or 5 patients. This is a reality, that because the human resources have been overstretched we have equipment that are not matched with the personnel to run the equipment. That's a reality that we have to deal with. We have, of course, learned a lot from COVID-19. We would not have a virtual component probably if we had not had of this convention, if we did not have COVID-19. But courtesy of that, we have been able to quickly take up technology as a means of delivering messages, as a means of capacity building, as a means of doing a lot of things that ordinarily we would do physically. And I am happy that even as we undertake this convention, we are able to stream to participants who are not here physically. We also have plan to establish a whole government approach to issues. We're talking about how the COVID-19 has been managed as a national security issue, where we are engaging the Ministry of Interior, the Ministry of Education, all the ministries, Ministry of Tourism. We have engaged all the ministries to ensure that we have one government approach to issues. I think that is one key message that we have learned. Even the deployment of COVID-19 vaccine that we are undertaking, we have used that system. When we use that system, we are able to do more with less resources. So I think that has been one lesson. We also learned from COVID-19, and I think that is what bore what has now been established as the National Public Health Institute, which is able to guide the country in disease surveillance, in disease monitoring, epidemic monitoring in one place, because we need to have, just like we have the National Intelligence Service, we need to have a National Health Intelligence Unit, which is the NPHI, which was gazetted last month by His Excellency the President. So these are some of the gains that we have gotten from. The ministry is still focused on delivery of UHC. And like I said, NHIF as an organization has been chosen as the organization, as the agency that will deliver UHC. As a strategic purchase, we have to always remember that there will be no UHC without primary healthcare services. Primary healthcare services means we have to work as national and county governments to establish primary healthcare networks, so that with a growing trend of non-communicable diseases, we are able to screen and manage non-communicable diseases and other communicable diseases and illnesses at community level, so that we are able to refer to the nearest facility. And this should be every citizen living in this republic, if UHC to succeed, must be mapped to a primary healthcare facility, so that we are able to say, I, as Dr. Mulwa, lives in Makueni, in Watuka village, I am linked to Uviluni dispensary, and the community health workers, the community health volunteers who are attached to my village are ABCD. They are able to visit my family. They are able to ensure that family planning, child health issues, cancer screening of NCDs is done, so that every person who is above the age of 50 is able to undertake some of the screenings that are supposed to be undertaken, so that every child who is supposed to get immunized is immunized. And by so doing, we'll be able to succeed. I think bottom line, so that I don't take a lot of time, is COVID-19 should be a wake-up call. We would be stupid, for lack of a better word, if we don't learn from the disruption that COVID-19 has brought to the health system. And as a ministry, we now know the value of healthcare workers. As a government, we know the value of healthcare workers. Minus the healthcare workers seated before me and others who are out in the field at this moment, dealing with emergencies and other health issues of the public, we would not be here. We would all be staying at home or probably dead. With those remarks, asanteni, God bless you.
Thank you, Dr. for that essential grasps of the issues. I'm sure now we are so much enlightened. But to add the icing on the cake and put the guardrails, Daniel Kimani from CDC will give us some empowering remarks, I'm sure. Thank you. Take it away.
Thank you very much and good afternoon, everyone. May I have my slides? So I'm delighted to be in this conference. I'm honored. I thank the organizers of the conference to come and share some of our findings in relation to access to universal health coverage and also the status of safety and our healthcare spaces. And I'll just follow up from where Dr. Mulwa has made a high-level presentation. I'll be presenting specifically on how UHC was impacted by disruption of health services and give a specific example of one health center in Nairobi and try to extrapolate that to the national. So I'm waiting for my slides. Just as I wait for the slides to mention that, as you said that we are the soldiers fighting COVID, to mention the end at the beginning that as soldiers, as healthcare workers, we realized that the risk of getting COVID was 12 times higher than the general population. So I'll talk about the impact of COVID on UHC and specifically address Gara Health Center. I'm Daniel Kimani, a public health specialist working with the Centers for Disease Control. That is the outline of my presentation. And just to start by saying that Gara Health Center, and I'm giving this as an example, what we found in Gara can be replicated in any other facility in the country, but we can use the lessons learned in this facility to see how we can build better our facilities where we all work in. So this is a facility that was contributing to over 250 outpatients with 61 staff. It also has a special section of methadone-assisted therapy where addicts come every day to access their care. So you can see the kind of numbers that they deal with. But early on in the COVID onset, remember the first case of COVID was on 12th of March in Kenya. But within the next 2 weeks, a healthcare worker got infected. And I'm unable to push this forward. Okay, thank you. So a healthcare worker got infected within the next 3 weeks. And this was early in the pandemic. Nobody knew how to deal with COVID. So the reflex instinct was actually to close the clinic, initially with the purpose of closing it to quarantine the healthcare workers for 14 days. The MAT clinic remained open. And CDC and the Ministry of Health carried out a risk assessment to just find out how the situation was and how that could be improved. Follow-up testing was done where it was found that additional healthcare workers had been infected, including a contact of the first healthcare worker that had been infected. I think the system has gone down. So just to continue talking is that although the initial plan was to have a closure of 2 weeks, because of additional infections, the facility continued to be closed for a total of 41 days. If you calculate back to the number of patients we were talking about, then we'll be able to see the impact. On the immediate, CDC worked with the Ministry of Health and other partners to arrange for the quarantine of the staff, to do contact tracing, trying to find the index case and other contacts where they were. It was a tedious activity. We also did provide support to address issues of infection control, including triage management, hand hygiene, PPE, tried to put up an electronic medical record system so that in future it's easier to reconstruct health records, and also had other delegations coming to the facility to actually learn from the technical people will take. Thank you very much. So when you extrapolate that just within this one health center, how many patients would have missed opportunity to access services? And we are talking in the context of UHC. We calculate that about 12,300 outpatients, and this includes the routine care, MNCH, TB, and other services. Inpatients missed. Home delivery increased because the maternity ward was closed, which was having 16 deliveries per day. And over 1,000 HIV patients may have missed their visits. So what this means is that either those patients went to other facilities, which again increased congestion in those facilities, increasing the risk to the healthcare workers, or they actually missed the service altogether. We did carry out an assessment using multi-stakeholder team and using a standard tool, and I'll shortly share the findings. I'll share 5 areas of findings. The first one we looked at is how was the infrastructure, and we found that there was a poor ventilation, crowding patient waiting bays, inadequate hand hygiene facilities, and this is cutting across many other facilities. In terms of infection prevention and control programs, this is something that had been neglected. No IPC committees. Many people had not been trained on IPC because that was not prioritized. There were no COVID specific training, and also there were no IC materials available. So people are groping in the dark with this new disease. Looking at the issues of PPE, we found that there was inadequate PPE for the healthcare workers. The little that was there was incorrectly used. For example, N95 when available was used across board despite the recommendations. And there was no specific places to actually don and doff this PPE. Now, looking at occupational health and safety, and I'm happy my namesake, Dr. Kimani, is also here, whom we've worked before. There were really no OSH guidelines for the healthcare sector. This is a document that we developed way back in 2014 with Dr. Manasseh Bocha here and others, but those was not available. There were no OSH program. Healthcare worker placement was not considered. For example, one of the healthcare workers that was infected was actually having a chronic disease that placed that person at risk of infection, so diabetes. So those are things that are not considered at the workplace. Issues of HBV vaccination was suboptimal. No surveillance system, for example, knowing how many healthcare workers actually get TB at the workplace. Yet we know so many got COVID. We also suspect that in the same circumstances, others could be getting TB. And finally, on the area of environmental cleaning, we found that there was also a gap in that area. Now, looking at what we were able to do and talking about building back better, of course, these are simple measures that can be implemented with the support of the county governments. For example, just ensuring that triage systems are available that reduce the risk to healthcare workers, donning and availability of PPE, hand hygiene facilities, looking at, for example, we see these in many facilities, sometimes the storage of things that are old or other commodities in the wrong places. And it is these simple measures that, for example, impede the airflow and actually increase your risk. Looking at, for instance, the issue of some tents. You have seen many facilities. These were tents were put sometimes by partners for HIV testing, but they become also places where there is no ventilation, and therefore they increase the issue of risk. Creating pathways to improve the patient flow, that would be some of the things we did in Gara. Of course, trying to provide tools to build the capacity of the healthcare workers, including IEC materials, trying to provide online trainings and webinars that we had to quickly disseminate the ministry's guidelines on IPC, activating the IPC committee that can be specific in doing risk assessment within the facilities that they work in, and of course improving cleaning of the whole facility. Finally, looking at some of the reflections and the conclusions. Yes, I have 2 minutes. Thank you. The first one is to say that when a facility is closed, it leads to a lot of disruption of services. I gave an example of Gara, but we all know in the different places that we work, many facilities were closed, and therefore all the people that would access services there would be at risk. But having found the situation in Gara, we did support an assessment, a risk assessment in 777 facilities across the country. And what we found is that they were doing badly in terms of infection control, getting an overall score of about 61%, and some of them really performing very badly, which meant that increased the risk of healthcare workers. And that is confirmed because when we analyzed the risk of a healthcare worker getting infected, it was 12 times higher than the general population. And therefore, I conclude by saying that a safer workplace and a safer healthcare worker requires a good IPC program that will prevent disruption of services and closure, and therefore lead to attainment of universal health coverage. I want to acknowledge my colleagues, Dr. Linus Ndegwa and Njeru, that are here, Gara Health Center staff, NMS, University of Maryland, University of Washington, and ITEC, and request you to keep safe always. Thank you.
Thank you so much, Dr. Daniel Kimani, for that presentation. As healthcare workers, we work in very dynamic and emotionally straining environments. And one of the main topics of discussion as healthcare unions is occupational safety and health and our safety at the workplace. I know that if we look at the COVID-19 statistics, we seem to have done well in terms of the number of deaths being low, but as healthcare workers, those who have come across that's something that we live with. When we face a death or a poor outcome, that is something that we live with, right? And we have to internalize it for the rest of our lives probably, and that affects our mental health at work and safety. So pre-COVID and post-COVID, what have we done to improve occupational safety and health of healthcare workers? Some of the factors that affect our safety is the healthcare workers, our numbers at work. Do we have enough of us working? Are we facilitated well? Do we have enough support staff? Do we have equipment that can support our work in a good way? So the next speaker that I'd like to invite is Dr. Wilfred Kimani, who will be covering occupational safety and health pre-COVID and COVID-19 and healthcare workers' occupational safety and health workers' safety at the workplace. Thank you so much. Dr. Wilfred Kimani.
Hello, thank you very much, Dr. Good afternoon, ladies and gentlemen. And if you could put up my PowerPoint presentation. So good afternoon all. I bring greetings from my boss, the Secretary of Occupational Safety and Health, Dr. Musa Nyandusi. I think he'll be here tomorrow, together with our Cabinet Secretary and the Permanent Secretary. So when we received the invitation to come for this conference, we were very privileged, and we gave it a lot of priority. As the Director of Medical Services, Dr. Mulwa said, and my boss in the union, Dr. There is always a silver lining in every dark cloud. And COVID-19, I think, helped us reorganize our priorities. As the DMS said, the country shut down because of a public health emergency. And previously we thought only nuclear holocaust could do that. So it brought back to fore the importance of health workers in the Republic of Kenya. Now, of course, you were the frontline soldiers, and this pandemic affected you. You're at higher risk, and as the statistics that Dr. Daniel Kimani showed, you are 12 times at higher risk than the general population. So at DOSH, I just wanted to highlight a few things, then I give you the information that we have. Next slide, please. So the Directorate of Occupational Safety and Health Services is a department within the Ministry of Labor. Occupational safety and health internationally is considered to be one of the labor standards. But of course, the International Labour Organization, being a UN body, works very closely with the World Health Organization, because you cannot separate the two. They collaborate even at the global level, at the regional level, and even locally here. And we've partnered with Manasseh and other members of the Ministry of Health in very many projects, and we are always willing and able, actually even with the unions, your predecessors. And we hope that you'll also be, anytime you have a query, we are open for consultation. So this is our mandate. We regulate or enforce a law called the Occupational Safety and Health Act of 2007, together with its subsidiary legislations, normally in form of legal notices. And the purpose of this law is to prevent accidents or diseases occurring in the workplace. So it is a preventative thing. Then we also administer a sister law called the Work Injury Benefit Act, WIBA 2007 in short, which provides for compensation of workers who have been injured or have suffered a disease out of and in the course of employment. Now, this is our vision. We envision a healthy worker in a safe work environment. And of course, the definition of healthy worker is the WHO definition. And this is our mission, to promote a safe and healthy workplace by implementing effective systems for the prevention of occupational diseases, ill health, accidents, and damage to property, in order to reduce the cost of production and improve productivity in all sectors of our economic activity. The chair of the Health Committee, Professor Anyang Nyong, Honorable, mentioned the issue of productivity of the health worker. So by extension, when you improve occupational safety and health, you'll also improve the productivity in many ways. So those are our core functions. I don't think, so we do systemic inspections and auditing of workplaces to promote the best practices and ensure compliance. We carry out examination of specialized workplace equipments, including things you get in hospitals, especially level 5 and 6, steam boilers and steam receivers, gas cylinders, refrigeration plants. We have our colleagues from the Mortician Society. They deal a lot with these refrigeration plants. And of course, we know when they break down the kind of challenges it can pose. We also identify, evaluate, and control workplace hazards, which could be biological hazards, chemical, physical, psychosocial, ergonomic, and any other factors in the work environment which can affect the safety and health of employed persons. We also do medical surveillance for workers who are exposed to certain hazards in the workplace. We carry out medical surveillance. And the aim of this medical surveillance is to ensure that the safety and health management systems you have put in place are actually functioning. Because if they're functioning as designed, then you should not have any worker who's going to be diagnosed to have an occupational disease. And if one is diagnosed, that means there is already a gap in that safety and health management system. Then we also carry out training and awareness creation, and of course ensuring compensation for those workers who unfortunately may have been injured or died in the workplace. We also carry out investigations of workplace accidents. We approve architectural plans for buildings intended for use as workplaces, so that we bring in the occupational safety and health aspects. My colleague, Dr. Daniel Kimani, mentioned the issue of the workflow. There is a standard architectural plan for health centers and clinics. And it was designed to allow the workflow so that the patient enters from the point of contact and continues out in a laminar manner, if I may use that word, instead of crisscrossing from one point going back to this other one, going there. It's meant to be laminar so that you, whatever infectious disease you may be having, or the risk is reduced to staff and also other healthcare seekers. Then, of course, we measure workplace pollutants for purposes of their control. If you say this place is having what we call volatile organic compounds, these are vapors, normally hydrocarbon substances that evaporate, and if you inhale, they cause occupational lung diseases. We need to measure so that we have an objective measurement. If it's saying that this worker is working in a high noise environment, we need to measure the noise. So I think that was my last slide. Now, what is our experience? So far as the directorate, we have received 40 claims for compensation for COVID-19 since March 2020. Of course, we know this is a gross understatement. We know there are more healthcare workers who are likely to have gotten COVID-19 from the workplace, but out of certain challenges, and the main challenge we have seen is lack of awareness. There are quite a number of documents that are available. In fact, as the regulatory authority, as the directorate, we actually have partnered a lot with the Ministry of Health. We customize a lot of documents for Ministry of Health. So I just want to mention two of them which are already in play, and Dr. Kimani and Gamaliel and have mentioned there one. There is one called Occupational Safety and Health Policy Guidelines for the Health Sector in Kenya. We partnered with the Ministry of Health and CDC and other development partners. It was published and officially launched in July 2014. This document breaks down the Occupational Safety and Health Act and customizes it for the health sector in Kenya from level 2 up to level 6. So it's very detailed. It goes to what you need to do. But just to highlight a few of those requirements, Dr. Daniel Kimani mentioned about the Infection Prevention and Control Committee. This document also requires, and even the law, that all workplaces in Kenya that regularly employ 20 or more members of staff should have what is called an Occupational Safety and Health Committee. And this committee should have a chair and a secretary and committee members. It should meet at certain intervals, and their agenda is purely occupational safety and health matters in the workplace. They don't discuss other agendas. This document also gave an administrative structure on how occupational safety and health will be implemented in the entire Republic of Kenya, starting at the national level with a focal person on occupational safety and health at the national level, and this was left at the discretion of the Ministry of Health. I think Dr. Kimani and we had proposed probably the cabinet secretary, and if he or she is not able to do that, they can delegate to another senior member in the Ministry of Health. Then we come to the county level. There should be a county focal person, the sub-county focal person, then down to the institution or the particular healthcare facility. It should also have a focal person on occupational safety and health. Then this Occupational Safety and Health Committee, once it is constituted, within 6 months of its constitution, the membership should undergo a standardized occupational safety and health induction training, which empowers them so that they're able to know what is it that is required in order for them to comply with the Occupational Safety and Health Act. And just as a by the way, the Occupational Safety and Health Act is not a document that, or a law that Kenya reinvented. We adapted and borrowed from international best practice, starting with the ILO and other organizations to come up with this act. So the Safety and Health Committee should also be formed in all facilities together with the Infection Prevention and Control Committee. Now, in the safety and this document, it has a document that will be used in the event that a worker is suspected or confirmed to have been exposed to, we are specific to COVID-19 here, to COVID-19 from a patient, there is a form that you should use to report this occurrence. We attached it as Appendix 1. It's also called MoL/DOSH 1. It is a form for reporting either suspected or confirmed occupational disease or an occupational accident, or unfortunately even a fatality. And the law requires, if there is a fatality, it should be reported within 24 hours to the nearest directorate office. If, sorry? Oh, okay. Then there is also another document I wanted to raise, which is already there, the National Infection Prevention and Control Guidelines for Healthcare Services in Kenya, December 2010, which also has very clear IPC guidelines, including what to do on IPC. And in the event of the occurrence of an workplace accident, an incident, including needle prick injuries or a spill of biological contagious material, it has a specific form that should be used to report that. Now, of the 40 cases we have received, only around 50% of them, interestingly, majority are from Garissa County and Wajir County. We haven't received from any other county. So I know you guys are distributed all over the Republic of Kenya. I've shared with the Secretariat these documents, so please disseminate them, because we know there are more people who've gotten that. But for whatever reason, people are not reporting. Then lastly, building back better. What have we done as the Directorate? We are continuing our additional collaboration with both the national and county governments. For us as DOSH, we are still a national government function because labor was not devolved. But as we were trying to implement and enforce OSHA 2007 and WIBA 2007, we realized that we have to engage the county government, and we have done that officially at the policy level and also at the technical level with the medical committee of the Council of Governors. We have trained them on what the Occupational Safety and Health Act compliance requirements are and the Work Injury Benefit Act. And they have started implementing, albeit gradually. Then we have continued training and awareness creation on occupational safety and health. Even as we speak, we have a team who are in Kisumu County raising awareness of this. Next week will be in Kericho County. Then we have also, through our secretary, issued several COVID-19 workplace advisories, starting with the first one that was on March 2020, another one in June 2020, and one that was specific for the healthcare sector that was dated 2020. And we continue to engage with anyone who consults us for advice. So I think I'll stop there, ladies and gentlemen. Thank you very much.
Thank you so much for that. We're running short of time, so we'll be going through the next session. We'll have a timer on so that if you have 1 minute left, there'll be a beep that will guide you so that you can finish up. The total time for this speaker will be 5 minutes. The next speaker that we have is Dr. Mercy Njeru from CDC Kenya. Thank you so much.
Yeah, so I wish we can get the presentation on, but I'm not sure I'll be able to run through the presentation. Based on that limited time, I'm Mercy Njeru from CDC, and it's a pleasure to be here. And so we'll be talking about mental health in the context of COVID-19. And we still don't have the presentation, and so I'll go on, but I wish you can just pull it up. Yes. and I just go straight to how WHO defines the issues of health. And we talk about this being a state of complete mental, social well-being, and not merely an absence of infirmity. And I know all of us know that. But when we talk about mental health, this is a state of well-being where one recognizes their abilities and can again be able to be productive in life, yeah, and be able to handle their stress levels. And so now moving to the next thing, and we look at some of the guiding principles, and one of them being mental health being a human right. And then there's the issues related to equity and how key this is, again, when we talk about social economic aspects, because if we are not mentally well, then that will impact our productivity at the end of the day. And so then having this being a people-centered approach, and that includes making sure that everyone is involved in decision-making, and then again, making sure that there is a participation in implementation of interventions. And so those are the guiding principles in matters of mental health. I will skip this. I believe at some point these slides will be shared, just to take care of my 5 minutes. And so what is the impact? Not sure why the system is not complying. Yes, what is the impact of mental health? And one of the things, and all of us would agree in relation to COVID-19, there was a lot of stigma and discrimination. Dr. Daniel Kimani talked about our experience as we visited one of the facilities that he talked about. And I can truly tell you, one of the things is stigma. I remember as we dialogued with one of the health workers there who had contacted COVID, one of the things they said is that we have no courage to go back to work. And especially because anytime they would walk even near the facility, the community around there would tell them, they would be called the facility, because it was, I think, the first case that was reported within the health workforce. And that facility was closed, and they would be told, either hospitali or COVID. And so that in itself brings a lot of stigma to the health workforce. And so, yeah, I think I just follow my notes. And areas of healthcare are workers' mental health of concern, and one of them is fear. One of them that we'll talk about is fear. It seems like the system is slow. Sorry. Yeah, one of them is fear. And so, forget about the slides because of time, I won't follow that now. One of them is fear and anxiety. Because you being the health worker, and especially in those initial stages where very little was known about COVID-19, you are there, you've had information through the different media, and you have seen what is happening in other countries. And here you are, a health worker, and you're supposed to be in the front line, as we were told, and you're supposed to respond and address cases that you're not even sure what the outcome will be. And also your own exposure again becomes another issue. And so that in itself brings fear. And so as we think about health workforce, what are the things that would stand out as stressors that we would need to address as we talk about mental health? One of them is constantly seeing human suffering. And you can imagine this healthcare worker who was working in an isolation center, yeah? And the frequent cases of people needing support, and at times ICU support. And that becomes the people you see every day. And so that being the case, that in itself becomes a real stressor. Issues of the fear of infectious diseases, high workload, which has already been alluded to, and in some cases, separation from our families and loved ones, in that case, impacting us again. Our social system becomes again something that stresses us because we are not getting the support that we would need. And so what we did in the course of this, being a part of a team that was responding to COVID, working together with the Ministry of Health, we did a risk assessment or a case control study looking at risk factors that would impact our health workers and that would lead to the exposure of our healthcare workers. And one of the things that we asked our healthcare workers, it is whether they were able, in the process of all this, to get psychosocial support. Did they get intervention in relation to psychosocial support? And in this, the age category of the majority of the people we dealt with, which was around 422, 178 were true cases that had tested positive for COVID using the PCR method. And for 244 were those who had some exposure but ended up testing negative to COVID. And asking each one of them whether they were able to get support in the process. 62% of the cases said yes, they were able to receive support, whereas the rest said they didn't get any psychosocial support or mental health support in the process as they dealt with COVID-19. And for the controls who are the negative ones, 46% told us that they were able to get psychosocial support. But we also had created an opportunity to see whether for those that already got or didn't even get support, whether they tested positive or negative, would they consider getting additional support? And we worked together with the mental health department in the Ministry of Health, and we had counselors online able to help those who would request for additional psychosocial support. And looking at that, we had 28% of the cases saying we would really appreciate if we got psychosocial support, additional psychosocial support. And for those who had tested negative, again, we had 22% of them saying they would really appreciate psychosocial support. And so what are we seeing? What are the things that really would stress a healthcare worker? And based on the things that they told us, supply chain issues, the lack of adequate supply chain related to personal protective equipment. When you feel you are not safe as you work with a patient, that in itself impacts you as a healthcare worker. So looking at systems that would ensure we protect our healthcare workers by making sure that we have adequate personal protective equipment, that is critical. The issue of how results were relayed back to the client, to the patients, to the healthcare workers. Some of them actually, this is verbatim. Like there are some who told us, my results were posted in a WhatsApp group. Yeah, we are quoting health workers and their responses to the questions that we went through. And we were working with the ministry, so they are preview to these responses. Results in a WhatsApp group, whether negative or positive. Is that the right way? What does that do to that healthcare worker? Assume they were positive. What does that do to that healthcare worker? Time even when the communication of the results were done. Some said, my results were sent via SMS at night. I couldn't get any mental health support. I hear my time is up. And so what can we do as we deal with these issues? Because these are the reality. The other things that we found out were even the categorization of departments within a health facility, where some people, just because of a risk assessment that is done, they are categorized as not priority in matters of being given PPE, like administrative staff. Like we had one case where they had an oncology department, and based on risk assessment, they were deemed not to be a priority to receive PPE. And so they had to sort themselves out or work without PPE. And so these are issues that at the end of the day will impact the mental health of a health worker, because as long as they don't feel safe, they have a problem at the end of the day. And so we need to look at this individualized interventions. What do I do as a health worker to make sure that what is accessible for me within a short time, like even taking care of one another as healthcare workers, encouraging, reviewing each other, that buddy system that we have already talked about before in many other forums, where you have somebody you can debrief with on how you are doing. Also having sessions within facilities which can provide an opportunity to assess how your staff are doing. And I'm talking to association people. And so these are things that we can implement within our healthcare workforce. Other things include systemic issues that we need to look at. Provision of PPEs, ensuring we have good numbers of our healthcare workers so that we don't have overloaded staff. These are things that we need to address if truly we mean it that we are taking care of our healthcare workers' mental health. And so I end it at that, not able to go through the slides, but these are realities and we need to look at these. I hope the presentation will be shared so that you can even hear the healthcare worker voices in that. Thank you very much.
Thank you so much for that short presentation. And as she rightly mentioned, occupational safety does impact on mental health, and I think those are conversations that we will continue to have in our panel discussions. The next speaker that we have is Sarah Kosgei from AMREF, and it's an online presentation. Is it ready? Is it ready, or we can go to the next presenter? I don't see anyone who is in charge of the online webinar sessions. So I think we'll just move to the next one for now while I wait for Mary Boniface to come back. So we can take Dr. Patrick Monyoki next. Thank you so much.
Thank you. We can have the slides on. Good afternoon. I'm Patrick Monyoki from CDC Kenya. I'm an epidemiologist, and I will speak more on numbers now on the COVID situation, and also how COVID has impacted the healthcare utilization. And I'll use a case study of 2 sites that we work in, one in Kibera and another site in Western Kenya, in Asembo, Siaya County. Next slide. So I'll start with that slide just to remind you that we've seen 5 waves of COVID circulation in our country. Most recent Omicron that from the recent data suggests that we are below 1% positivity rate. Actually, for the last 3 days, we've seen 0.3% positivity rate in our country. That gives us the basis actually to also understand what is happening in other sites. Next slide. So we've set out a population-based infectious disease platform, and that's what I will speak on, and then move on to what we found in terms of our COVID surveillance and how utilization of services has been in these 2 sites I've mentioned. So as a way of background, the population-based infectious disease platform that we run is in 2 sites, a rural and urban site, and it's involved following a cohort of over 25,000 participants in each of these sites, a population that is well characterized with visit frequently in their households to get to know their health status and health-seeking patterns. We also have surveillance at health facilities that are centrally located in each of these sites, where we do we enroll patients who are presenting with respiratory illness, diarrheal disease, and acute febrile for further testing. So essentially, the platform was set to look at the burden and etiology of common infectious diseases and emerging infectious diseases as SARS-CoV, as taught us. And since it's a longitudinal kind of surveillance, we've been able to look at impact of interventions in this population. So I will move on to what we found in these particular settings, starting with Kibera. Next slide. So Kibera, the red line is what you need to trail your eyes to. Shows the positivity rate from May of 2020 when we engaged this site for SARS-CoV surveillance. And you can see the PCR positivity peaked out the 5 waves that we observed in the country from this particular site in Kibera. And one thing also to note is that in the course of these, we also did surveys which tell us about the exposure of the population to this virus. we see that in December of 2020, it was around 43%. In March of 2021, moved up to 56%. And then by June of last year, then it was at 64%. If we had done another sero survey after the Delta variant wave, we would have seen it higher. And you note that towards the end of last year, beginning of this year, we had the big wave of Omicron. Something that tells you that these new variants actually were more transmissible than the previous ones, because they were able to penetrate in a population that has high exposure to the virus. One thing that I want to note, and I think it's something that seemed to emerge with the easing of restrictions, is that the virus is still in the population. Like in Kibera, in the last 3 weeks, we've been able to detect 4 to 6 cases every week. As of today, we had our samples that we collected yesterday, 4 of them turned out positive. So it indicates the virus is still in this crowded population, and these are population that serves the entire country. Not posing any alarm, but just saying that the virus is still in the country. Then we observe the same data, next slide, we observe the same patterns in Assemble, the western site, though slightly different. In Western Kenya, we've seen only 3 waves that are not very synchronized with the national data that we've seen earlier. One wave that was not very, the transmission was not high, as you can see from the peaks. But again, the Delta and the Omicron waves peaked quite well in this particular population. So prevalence after the Delta wave was at 45%. Again, we are planning to do another survey in this population just to see where we are. And that, against the vaccination coverage, will tell us what the population immunity looks like. Next slide now talks about the impact of these COVID circulation in the population on healthcare utilization. There are many lines there. It's showing the different years before and during COVID. So the gray lines are the before COVID, and you can see that for the colored line, which show the COVID period, and trailing your eyes to the red line is that once the COVID came in March of 2020, there was a decline in healthcare utilization. Patients were not coming to the clinic due to fear of being exposed. And again, that was sustained for a few months before we resumed to the pre-COVID levels and even higher throughout the other years. Next slide. So essentially, the healthcare in this particular setting was able to recover. And one of the reasons why that happened is because we provide free healthcare to these patients in the areas that we do. So universal health access probably would provide that elasticity and resilience of the health facility. Then a similar pattern was observed in Western Kenya, decline in healthcare utilization and in this setting. Next slide. One thing that I wanted to mention is that despite the reemergence or people coming back to the clinic, we see reduced cases of respiratory illness, diarrheal illness, febrile illness coming back even during the COVID times. Something that could be potentially associated with the interventions that are taking place. So I would say we need more sentinel surveillance sites across the country so that we can know whether the virus in the population, and this tells us the amount or the energy that needs to be there related to IPC measures in the various health facilities. And from this particular data, we've been able to see that the facilities that have free access to care where we work in were able to recover to pre-COVID times in terms of people coming or wanting to access healthcare in our facility. However, we note that decline in respiratory illness, which could be attributed to interventions, face masks, distancing, and something that we're investigating in our setting. And I would end by recognizing this work was done and driven mainly by KEMRI with funding from CDC. And GAIS funded the zero survey work, and WSU also are involved in the implementation of the work. We also relay these data on daily basis to the Ministry of Health, to NMS, on the cases that we detect in Kibera, and also respective to Siaya County for the cases that we detect in Asembo, and help that in COVID response. Thank you.
Thank you for that presentation. Sarah Kosgei's presentation is now